every ophthalmologist has had those patients come into their clinic with a history of radial keratotomy or RK. And many of those patients want very good vision because they, in the dawn of refractive surgery, they elected to have RK. However, now they're getting to be a little bit older and they realize that their vision may be fluctuating throughout the day, or their vision has had a hyperopic shift and they're not as happy with it. And so when it comes time to doing cataract surgery, oftentimes people will use special post-RK formulas to try to select lenses. And patients aren't that happy even after the cataract surgery, despite going to those efforts. And so when we see those patients in our clinic, we have a couple of options. One option is to exchange their IOL with an Apthera or a pinhole IOL lens. That pinhole IOL lens often is a good option for patients that are willing to spend premium prices for their IOLs at the time of cataract surgery. But sometimes it's more difficult to exchange the IOL after they've already had cataract surgery. So one of the options that we like to do is perform pinhole pupilloplasty for these patients, especially if when we see them in clinic, we flip down the pinhole and they're seeing much better than they do with uncorrected or corrected vision without the pinhole. And so I want to walk you through one of our recent pinhole pupilloplasties and kind of talking about some of the nuances of the technique that we use. And so here we're starting out making our incisions with the diamond side port blade, giving a little bit of additional lidocaine into the eye. And I want to stop it right here before we really get started and look at the dilation of this pupil. So this pupil is fairly fairly dilated, even though we've put in preoperative pilocarpine to see how much we could get the pupil down prior to the start of the case. And so after making our incisions, we put in the AC maintainer, and then we're going to start the pupilloplasty, and we want to really get it down to a very small pinhole sized. And so we'll start kind of peripherally with with the sutures, and then bringing it more and more central and making the pupil smaller. You don't want to get too central from the beginning because then that can make the iris lopsided or tilt it up or down. And so I'm going to start over here on the right-hand side and really take bites that are symmetric distances from the pupillary margin, and trying to be also at symmetric distances from the center of the eye as well. And so I go in and come out the iris and then straight out through the cornea. And so because I do that, we only have to make really one incision that we're working through. And then after I pull the needle all the way through, I take a push-pull and grab the distal end of the suture, the far end of the suture, and pull it back out to create a loop while I'm holding on to the other end with some ties. And then I take that loop and take the distal end and throw it through 4 times, hence a 4-throw pupilloplasty. So single pass, 4-throw. We do the reverse technique. You can watch some more of the details about that, the specifics of that in some of our other videos. But then after that, I pull tight and then trim the ends of the suture. And then you can see the pupil is a little bit smaller, but obviously it needs some more. And so I go in. While I go through the main incision, I really just do a sweeping motion to make sure I'm not making a new channel or a new pathway, and just going through the main wound so that I can bring things in and out more easily. And then again here, I'm trying to get equal distance from the pupillary margin and kind of both of those equidistant from the center of the eye so that everything seems more symmetric when I'm pulling it back. Take the push-pull, grab it, and pull out to make this loop. And so then again, throwing 4 times through that loop. Here you can see this at the beginning. I was throwing it through while the loop was a little bit twisted. That causes it where I potentially have 2 issues, or I have 1 issue from 2 potential problems. One from that loop being twisted while I am doing the throws through the loop. Another is when I pull apart the suture. So typically you want to try to save as much suture from the other end as you can so that you can throw as many knots as you need. But when I'm pulling it too much, the knot comes like disproportionately towards one side, and it kind of gets caught on the iris, and it kind of starts to cinch down that knot before fully closing it. And so you can see here, I'm having a little bit of a difficult time fully closing that knot, and we'll address this later on in the case, but that area of the pupil or the iris does not fully come down. So I just move on, go to the next suture, and with all the subsequent cases, after doing the throws and making sure that the loop is not twisted when I'm doing the throws, and then when I'm pulling it tight, I want to make sure that I'm pulling most of it from the far end or from the side on the opposite side of me where I keep most of the suture. But with the closer end to me, I still am, once it gets close to pulling tight, I really want to pull with both ends so that the pupil really comes down better before it tightens, I guess I should say. And so there you see it actually come together much more nicely. And then so now I'm going through with the fourth throw, again wanting to make them equidistant from the pupillary margin and both of those equidistant from the center of the eye, throwing 4 throws, and again trying to pull this a little bit more symmetrically, cutting those sutures. And on that side, you can already tell that that looks pretty nice as far as how I'm wanting it to look in the distance from the light reflex. The light reflex can be a very good guide on how small you want to make this pupil and kind of the location where you want to make it, because the patient's looking towards the light really most of this case is what we're telling them to do. So after this 5th suture, making those 4 throws, pulling it tight, I really see, hey, this is at a pretty good size where I want it. And I'm going to stop here, and you can really see the remaining pinhole pupil is about the size of the 3 light reflexes of the Purkinje images. And so that gives us a good idea that this is the appropriate size that we want the pinhole effect to be. But you can also see there's this additional area over here, over to the left on this, or over, I guess, what is this, superior for this patient, where that initial suture didn't pull tightly all the way. So I'm going to go in with another suture kind of overlying that instead of trying to snip it and pull it out. I really am just going with another suture overlying that one and closing that defect in the iris. And again, pulling it out with the push-pull and making 4 throws. And then here, just being a little bit more gentle on trying to make sure that this closes nicely. And you can see here that it does. And really with the final result looking like you've got this small pinhole and the iris really closed up nicely. This patient did really quite well, was already seeing better at their 1-day post-op than they were prior to their surgery. And we'll keep you updated with more of a follow-up there. But a lot of these patients with RK, these higher order aberrations, some of whom don't even do that well with scleral contact lenses, may benefit from a pinhole pupilloplasty if you notice their vision improving on pinhole during exam. Thanks for watching.